Welcome to this Step 2 clinical knowledge review on pregnancy complications in the second half of pregnancy. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for preeclampsia, eclampsia, gestational diabetes, preterm labor, placenta previa, and placental abruption, and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the obstetrics and gynecology sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for pregnancy complications in the second half. Second, we will apply specific strategies for questions about preeclampsia, gestational diabetes, preterm labor, and placental bleeding. And third, we will master the next best step question format for diagnosing and managing these conditions. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Our first strategy is the preeclampsia versus eclampsia split. When you see a question about hypertension in pregnancy after 20 weeks, immediately ask yourself, does this patient have preeclampsia or eclampsia? For preeclampsia, the key question is whether there are severe features. Look for blood pressure at or above 160/110, headache, visual changes, right upper quadrant pain, elevated liver enzymes, and low platelets. Without severe features, management is monitoring. With severe features, the answer shifts to delivery and magnesium sulfate. For eclampsia, the defining feature is seizures. Magnesium sulfate is always the correct treatment for eclamptic seizures, never anti-epileptic medications. The boards absolutely love testing this distinction, so make this your first mental framework. Strategy 2 covers gestational diabetes and preterm labor, two more critical second-half pregnancy complications. For gestational diabetes, the boards love testing the screening protocol. Screening happens between 24 and 28 weeks with a 1-hour glucose challenge test. An elevated result gets followed by a 3-hour glucose tolerance test for confirmation. Management starts with dietary changes and exercise, and insulin is added if blood sugar targets are not met. For preterm labor, the key concept is regular contractions with cervical change before 37 weeks. The most important intervention is corticosteroids between 23 and 34 weeks for fetal lung maturity. Tocolytics by 48 hours for the steroids to work. Magnesium sulfate before 32 weeks provides fetal neuroprotection. These are board favorites. Now let us go through high-yield stem recognition. For preeclampsia, the classic stem presents a pregnant patient after 20 weeks with new-onset hypertension and proteinuria, often with headache, visual changes, or right upper quadrant pain. The blood pressure values and presence of severe features drive the management decision. For gestational diabetes, the typical stem involves a patient between 24 and 28 weeks undergoing glucose screening, often with risk factors like obesity or prior large infant. For placental emergencies, the key is a third-trimester patient with vaginal bleeding. Painless bleeding means placenta previa. Painful bleeding with a rigid uterus means placental abruption. These stems repeat over and over on practice questions and on the real exam. Let us work through our first practice question. A 32-year-old woman at 34 weeks gestation presents with a blood pressure of 165/112, headache, and right upper quadrant pain. Lab results show elevated liver enzymes and a platelet count of 90,000. Urinalysis shows proteinuria. What is the most appropriate next step in management? Take a moment to think about this before we walk through the answer on the next slide. Let us break this down step by step. Step 1. Spot the pattern. Pregnant patient after 20 weeks with severely elevated blood pressure, headache, right upper quadrant pain, elevated liver enzymes, and low platelets. This is preeclampsia with severe features. Step 2. Apply the rule. The board rule is that preeclampsia with severe features at or beyond 34 weeks requires delivery. Magnesium sulfate is given for seizure prophylaxis. Never delay delivery when severe features are present at this gestational age. Step 3. Eliminate wrong answers. Expectant management is wrong because severe features at 34 weeks require delivery. Bed rest and repeat labs dangerously delays care. Outpatient management is never appropriate for severe preeclampsia. The correct answer is B. magnesium sulfate and delivery. Here is our second practice question. A 35-year-old woman at 36 weeks gestation presents to the emergency department with sudden onset, painless, bright red vaginal bleeding. She reports no contractions, trauma, or abdominal pain. Vital signs are stable. What is the most appropriate next step in management? Think through this one carefully. The key word here is painless. We will walk through the answer next. Let us work through this answer. First, read the question carefully. This describes painless vaginal bleeding in the third trimester, which is classic for placenta previa. Remember, painless bleeding equals previa, and painful bleeding with a rigid uterus equals abruption. A digital cervical exam is absolutely contraindicated because it can trigger life-threatening hemorrhage. Immediate cesarean delivery is not the right call when the patient is hemodynamically stable and you have not confirmed the diagnosis yet. Oxytocin would stimulate contractions and worsen the bleeding. Transabdominal ultrasound is the safest first step to confirm the location of the placenta before deciding on management. The correct answer is B, transabdominal ultrasound. Let us review the key management pearls for these conditions, because they come up constantly. For preeclampsia without severe features before 37 weeks, you manage expectantly with close monitoring. At 37 weeks or later, deliver. With severe features at or beyond 34 weeks, give magnesium sulfate for seizure prevention and proceed with delivery. Before 34 weeks with severe features, administer corticosteroids for fetal lung maturity and plan delivery within 48 hours. For placental abruption, management depends on stability. Fetal distress or maternal hemodynamic instability means emergent cesarean delivery. A mild abruption with stable mother and reassuring fetal monitoring near term may be observed. Know these algorithms well for exam day. Here is our third practice question. A 28-year-old woman at 26 weeks gestation undergoes a 1-hour glucose challenge test that returns a value of 195 milligrams per deciliter. She has no prior history of diabetes. What is the most appropriate next step in management? This is a classic screening algorithm question. Pay close attention to how high that glucose value is and what that means for the next step. We will walk through it next. Let us break down this answer. The classic pattern here is an extremely elevated 1-hour glucose challenge test value of 195 at 26 weeks. When the screening value reaches this level, at or above 190 milligrams per deciliter, many guidelines support diagnosing gestational diabetes directly without a confirmatory 3-hour test. That is the key distinction being tested. A 3-hour glucose tolerance test would normally be the next step, but with a value this high, it is not required. Starting insulin right away is premature because dietary changes and exercise are always the first line of management. Dietary changes alone without proper glucose monitoring is incomplete care. The correct answer is D, diagnose gestational diabetes and begin monitoring. Here is a critical test-taking pearl about preterm labor management. Corticosteroids are the single most important intervention between 23 and 34 weeks for fetal lung maturity. Either betamethasone or dexamethasone is acceptable. Tocolytics like nifedipine or indomethacin are used to buy 48 hours for the steroids to take full effect. Magnesium sulfate before 32 weeks provides fetal neuroprotection, which is a separate indication from seizure prevention in preeclampsia. Group B streptococcus prophylaxis should be given if the patient's status is unknown or positive. The exam loves testing these specific gestational age cutoffs. Also know that fetal fibronectin and cervical length measurement help assess risk, and a negative fetal fibronectin result is highly reassuring. Commit these details to memory. That wraps up our review of pregnancy complications in the second half. Test-taking strategies for Step 2 clinical knowledge. Remember to review the obstetrics and gynecology chapters in first aid and your question bank. Focus on the preeclampsia management algorithms, gestational diabetes screening thresholds, preterm labor interventions, and placental bleeding emergencies we covered today. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.